Good evening. Welcome to the first periodic tables of 2020. I was just talking to a colleague about the size of the Venn diagram between you all and people interested in the Duke basketball game. We think it's small. But anyway, it's great that you're here, whether you're indifferent to the Blue Devils or not. So before I introduce Yousuf Zafar, I want to tell you about next month, Tuesday, February 18th. We're going to have Herman Ponser, my colleague from Evolutionary Anthropology, and his title is Healthy as a Hunter-Gatherer, Sorting Paleo-Fact from Paleo-Fiction. And so he will talk about what living hunter-gatherer populations today can teach us about eating well, staying active, and avoiding heart disease, diabetes, and other diseases of modernization. So I'm very excited about that. Now, I'm also very excited about tonight's speaker, who I've actually stalked for a little while. For some reason that I'm not sure I could even articulate, I got very interested in drug pricing and healthcare costs a few years ago, and was thrilled to learn that one of the real leading lights in this area was across the street. I really encourage you, like drug pricing Twitter is a thing, and Dr. Zafar is a central part of it. He is also a gastrointestinal medical oncologist and healthcare delivery researcher. He is an associate professor of medicine and public policy at the Duke Cancer Institute and Sanford School of Public Policy, serves as director of the Center for Applied Cancer Health Policy at the Duke Cancer Institute, and his research explores ways to improve cancer care delivery with a primary focus on improving the affordability of cancer treatment. Tonight, I think he's going to take a little broader lens and talk about how money changes everything in healthcare. Yousuf Zafar.
Thank you. Thank you all for coming. It is really an honor to be here, and I'm excited to talk to you about this. I'll probably talk for about half the time and leave more than enough time for discussions about this topic. Before I start, especially with this topic being as straightforward and non-complicated as it is, I do think it's important to talk about and disclose nothing. I have nothing to disclose. This one right here? Yep. Okay. These are my disclosures, relationships, potential conflicts of interest. The most important one being the one at the top. My wife is also an oncologist, and she works for a oncology drug development company. So despite the fact that I spend all my days talking about how drugs are too expensive, I am literally in bed with the pharmaceutical industry. Fun fact, this is the first time I've used that joke with my wife and her coworkers in the audience. This will be awkward later. So this is a complicated topic, and usually when you think about healthcare and costs related to healthcare, you think about numbers in the billions or hundreds of billions, maybe even trillions. Those numbers are really hard for me to wrap my arms around. And so before delving into those numbers and thinking about what happens at the level of the health system, let me focus down and talk about it at the level of the patient or a patient. This is Silvia. Silvia is my patient. She was diagnosed with metastatic pancreatic cancer about a year ago. It's a tough cancer, as I'm sure many of you know. She didn't feel so great at the time of her diagnosis, and she had to cut back at her time at work. So her income dropped. She lost her insurance. Then she saw me, and I started piling on a lot of physically toxic and expensive treatments onto her. Without insurance, she accrued thousands of dollars in medical debt over the course of not months, but weeks, maybe even days. Without insurance, she went to North Carolina Medicaid and asked to apply for Medicaid. Remember, North Carolina is one of the states, one of the handful of remaining states that has not expanded Medicaid eligibility under the Affordable Care Act. And she was told that she earned too much to be eligible for Medicaid. This is how much Silvia earned at the time. My sort of back-of-the-envelope, unofficial calculations suggest that she'd probably have to earn down to $8,000, by the way, this is a year, in order to be eligible for Medicaid in North Carolina. How do we get to this point? How do we get to this point where we live in probably the wealthiest country in the world, have access to arguably the best health care in the world, some of it just down the street from us, and yet we have people who are employed, who had insurance, and yet can't afford basic health care. So, in fact, Silvia's not alone. And we hear more and more, and you guys have heard the stories in the news of patients who are impacted by the costs of healthcare. There's a really interesting study that was done in Washington State a couple of years ago, where for the first time they combined bankruptcy court data and cancer registry data. And they looked at the risk of bankruptcy related to cancer. And what they found that just having a cancer diagnosis increased the risk of declaring personal bankruptcy by more than double. So not whether or not if you're getting, a fancy new drug or if you have a certain diagnosis over another, but just having a cancer diagnosis was associated with greater than a twofold risk of declaring personal bankruptcy. So what, you may ask? And it's a callous but reasonable question. Like, so what if a person declares bankruptcy? They're getting cancer care, right? That's a good thing. Well, that's a really interesting question because the same group of investigators took the study a step further and answered the so what question. They said, well, so what? What happens if a cancer patient declares bankruptcy? And what they found was that cancer patients who declare bankruptcy were at 79% greater risk of dying. So this is an eye-opening, astonishing, and intriguing question as to why is that happening? Why is it that extreme financial distress can result in earlier death? In fact, this is a question that I've dedicated about a decade or so of research trying to answer. I don't think I've completely answered it yet. There are a lot of people in the room who've spent a lot of that time helping me answer that question. But we made some progress. In fact, the first study that we worked on asked patients who had cancer insurance, who had cancer, were getting treated for it, what they were doing to try to cope with all of these expenses. More than half of them had given up vacations. About half were spending less on food and clothing. About half were spending their savings, all to pay for their cancer care. And let me remind you, these are people who had insurance. So what else are patients doing to help pay for their cancer care? And I think this next point is potentially scarier because it has to do with the quality of cancer care, actually manifested in adherence to cancer treatment. There's a really cool study that was done at UNC where they looked at patients who were newly diagnosed with chronic leukemia. So if you know anything about the landscape of chronic leukemia, over the past 20 years, you know that it has completely changed. About 20 years ago, maybe longer, if you got diagnosed with chronic myeloid leukemia, it was a death sentence. And you had maybe a year. Today, because of this drug, actually this is a picture of the drug, it's imatinib, also known as Gleevec. People who get chronic leukemia, who get diagnosed with chronic leukemia, could live potentially a normal remainder of their life and might die of something else, all because of this drug. So this is truly a life-changing drug. So back to the study. The investigators in the study looked at people who had been newly diagnosed with chronic leukemia and who were just starting this drug, and then looked at their out-of-pocket costs in relation to how long they stayed on the drug. What they found was that patients who had higher out-of-pocket costs, monthly copays, for imatinib were 70% more likely to stop taking the drug. Okay, so what's a higher copay in this study? It wasn't thousands of dollars a month or hundreds of dollars a month. Statistically, it was higher than $53 a month. This is the scope of the problem we're dealing with today, in that $50 a month could induce somebody to stop taking a life-saving drug. And in fact, what we have today is an evidence-based list of financial harms that patients are facing. Each one of these is based on a study, and each one of these is what patients are doing to help pay for their health care, particularly in most cases, and here I'm talking about cancer care. And so the term that I've used to describe all of this is financial toxicity. So when I treat a patient for cancer with chemotherapy, they experience the physical toxicity of treatment. I would argue they also experience the financial toxicity. So that's what's happening at the level of the patient, right? How do we get to this point? How is it that this is happening in the US, but not necessarily in other parts of the world where patients are being treated with the same interventions? So let's zoom up now. Let's go up to the level of the health system now that we know what's happening at the patient level. To do so, let's first look at how much we as a country are spending on healthcare. So this shows spending on healthcare as a percentage of gross domestic product. In the US, we're spending approximately 20%, almost 20% of our GDP on healthcare, which is way more than our sort of comparable counterparts around the world. So this is a first warning sign, right? Is we're spending more on healthcare, okay? But what are we getting for it? If we're spending more, we should be doing better, all right? So let's look at outcomes, and let's start with one that is important, life expectancy. I'm leaving our sort of percent spend per GDP on the screen, just to give you an idea, keep it in mind, not because I'm suggesting any relationship between outcomes and how much we spend, okay? Just to remind you about how much we're spending, let's look at life expectancy. So you see over there, age in years, and this is life expectancy. In the US, compared to comparable developed economies. What else? Let's look at another outcome. Let's look at maternal mortality, something that I think all of you agree is a problem that we should have all dealt with at this point, all right? So this is maternal deaths per 100,000 live births in a year, and these are the numbers. Again, shown in context of how much we're spending. Not in relation to, but just in context of how much we spend. So despite the fact that we spend more than any other developed country, including Switzerland, which the rest of the world looks at Switzerland and says, how could you be spending so much? Our outcomes are considerably worse. So why is that? One of the earliest arguments as to why our health system was going to hell in a handbasket was around healthcare utilization. Right, so what do I mean by that? I mean, how much are we using healthcare resources, right? Maybe we're spending so much because we're using healthcare resources, and maybe our outcomes are not as good because we're not using them effectively. So let's take a look at healthcare utilization in the US. And we do that most of the time by looking at Medicare spending. So the more we spend on Medicare, that means the more we're using healthcare resources, right? So this is a heat map of Medicare spending around the country. The more red a state is, the more spending there is there in Medicare and the more healthcare utilization there is. So let's zoom down a little bit, look at one of the most spending states, one of the states with the greatest healthcare utilization, and that's Texas. Let's zoom in further on Texas and look at one little town all the way at the bottom of the state on the border of Mexico, McAllen, Texas. You're nodding. Why is McAllen, Texas famous? Number one for obesity, so really bad outcomes. What else? Anybody else know why? Recognize the name McAllen, Texas? Okay. Let's go with that one. So a few years ago, Atul Gawande, who is a surgeon in Boston, and a prolific and really wonderful writer. He's written a lot of books. He's written on being mortal. He's written multiple essays in the New Yorker. This one really brought fame to McAllen, Texas, because, like you said, for this article, he went down to McAllen, and he found that in McAllen, Texas, they spend more. They use, actually not spend, they use more health care than anywhere else in the country. And around the argument of what was happening in McAllen, Texas, he said, this is the problem with our healthcare system. We're using way too much healthcare. You guys have heard this, right? You've heard this argument. We do way too much here. You want an MRI? Go to your doctor. Day after tomorrow, you'll get an MRI. Got a bum knee? Go see your orthopedic surgeon. Got a bad hip? We'll get you a new hip next week. Maybe tomorrow, if you're lucky, if we can fit you in the OR schedule, right? This is a common story that we hear about healthcare in the US. Let's look at the data. So let's look at some measures of healthcare utilization. This is hospitalization or hospital discharges. So how much are we spending, how much time are we spending in the hospitals? If you look at the data, we're actually not hospitalizing our patients any more than most other of our comparable countries. Hospitalization is a huge expense. And in fact, if you look at cancer patients in the US, within 6 months of diagnosis, hospitalizations account for more costs than drugs, even though we pick on drugs so much. So hospitalization is a big deal. We're not hospitalizing patients at any greater rate than anywhere else in the world. All right, what else? Let's look at physician visits. How often are we going to the doctor? We're not spending more. We don't have greater utilizations of doctor visits than anywhere else. In fact, we got a lot less. So that's not a great measure of us using healthcare more than elsewhere in the world. What about procedures? I mentioned hips, right? In terms of hip replacements, again, we are comparable to the rest of the world. There's a ton more of these measures that I can show you where, for the most part, our utilization matches that of other countries, other developed economies. Maybe a couple outliers here and there, but for the most part, we're matching. So is it utilization? Is that the answer? You know, there was a group of really well-known economists who in 2003 got together and they wrote this paper in the journal called Health Affairs, really important healthcare health policy journal. And they wanted to answer the question of, is it utilization? This was the title of the article, I kid you not. It's not utilization, it's the prices, right? This is the problem in our country, and this is the argument that they laid out. Our prices are so far out of control. that spending on our healthcare system does not match outcomes and far exceeds everywhere else in the world. So let me walk you through what's happening with prices. So I'm going to show you the price of 1 month of chemotherapy, the average price across hundreds of different drugs, okay? In 1980, a month of chemotherapy cost less than $300, adjusted to today's dollars, okay? So this is just drug, not my fees, not hospital fees, nothing like that, okay? In 2000, a month of chemotherapy was over $3,000. That's a huge change. 2019, it went up to $11,000. So the drugs that I prescribed in clinic yesterday, right, were costing this much per month, and actually I would argue some of those are this much per dose. So drug prices have gone up considerably over the past few decades. I get that, right? But you could argue, well, that's happening globally. So let's look at how much we pay for drugs in the US compared to what happens elsewhere in the world. Let's go back to Gleevec or imatinib, right? This is how much we pay, right? Almost $11,000 for a month of Gleevec compared to the rest of the world. Let's talk about a drug that you may be familiar with, Crestor. This is a difference in price of Crestor in the US compared to the rest of the world. What about diabetes? Lantus. Same thing. I could just change all the names of the drugs. I could just switch the drugs around, leave the same graph. You wouldn't know. But that's basically what the data is this is the magnitude of difference between prices that we pay for drugs in the US compared to elsewhere. So I ask again, why? Why are we paying more? So I go back to those economists who wrote the article, It's the Price is Stupid, one of the most important articles on healthcare economics. One of those economists was Uwe Reinhardt at Princeton, who unfortunately passed away just a couple of years ago. It's really brilliant. And he wrote about the cosmic law of healthcare. And I would actually argue this is the cosmic law of American healthcare, which is every dollar in health spending is someone else's income. And I really think, I could just stop here, right? There's the answer. This is why we have the health system that we do today. This is why we pay as much as we do. This is why we don't do as well. It's because of this. But I'm not going to stop there. I'm going to show you why this is the case, all right? Let's go back to drugs. I know I pick on drugs a lot. I'm not only going to pick on drugs, but I'm going to stick with drugs for now. Let's look at a drug that costs a manufacturer $17 to make, okay? So it costs you're wondering, why is it all the way over there? Why is it so small? Hang with me. $17 to make, okay? So the manufacturer then sells that drug to a wholesaler, okay? So this is drug chain. This is drug supply chain. And there are a lot of people in the room who know this a lot better than I do, so I apologize if I'm messing this up. But a manufacturer makes the drug for $17, marks it up, sells it to a wholesaler to make a profit for $58. The wholesaler then takes that drug and distributes it to pharmacies, but makes some money off of that deal in the process. The pharmacy then makes a little bit of money and sells it to a pharmacy benefit manager or a PBM. I could spend an entire semester talking about PBMs. They're incredibly complicated. I don't think I even understand them completely, but most people refer to them as the sort of real estate agent within the drug manufacturing chain. So PBMs then negotiate prices, make a little bit of money, and sell the drug to a health plan. Now the drug's $81. And then in the form of premiums, health plans tack a little bit more on, and now you have a retail price of $100. So this is how a drug that's $17 to manufacture costs $100 in the US, but maybe doesn't cost $100 in Japan or in the UK. because there's a lot that happens. There are a lot of hands that touch this drug as it goes from factory to your pharmacy. But I said I wouldn't just pick on drugs. And in fact, drugs is just where the problems start. So who else is responsible for the problems of runaway prices in our health system? Well, you're looking at them. So yes, I prescribe those drugs. And sometimes I prescribe those drugs maybe with not the best evidence. But I also get paid. And this is a median salary for a general practitioner in the US, compared to what general practitioners get paid in the rest of the world. So physicians are clearly getting paid more than people elsewhere. And I have to admit, than physicians elsewhere, and people elsewhere, than physicians elsewhere. And I have to admit, that's contributing to the problem. So what else is contributing to the problem? One aspect of healthcare costs that I don't think ever gets talked about. I never hear it I never see it, people ranting about it on Twitter. I never hear about it on the news, but it's there, and it's health administration. So in 1968, in Canada, there were an estimated 40 healthcare administrators per 10,000 in the population. In the US, there were about 44 healthcare administrators per 10,000 of the population. In 2017, there were 89 in Canada and 130 in the US. So that's a lot, but I think it makes sense to look at how much we spend in healthcare administration in dollars. So in Canada, I think this was in 2018 data, they spend $20 billion in healthcare administration. This is how much we spend. So you can't tell me that there's no way that the amount that we're spending on healthcare administration isn't trickling down to how much you pay for your copay when you go see your doctor, or how much you pay for your medicine, or how much you pay for your colonoscopy, right? It all gets wrapped into there. And nobody's talking about the amount that we're paying on bill. So what is healthcare administration, right? It's the large amount of people we have to make sure that billing is done appropriately, to make sure that everybody's following all these healthcare regulations that we have and all of the bureaucracy. It's all part of this. There's another piece of the healthcare industry that is not talked about, and I think contributes a tremendous amount to our overall costs. Every healthcare sub-industry, insurance, hospitals, pharma, many large healthcare companies hire lobbyists. And those lobbyists go to DC, they get paid a lot, and then they also contribute to campaign funds for re-election. And they have a lot of influence when they lobby the Ways and Means Committee, right? So what's the House Ways and Means Committee responsible for? Budget for Medicare and Medicaid. So you can imagine, I mean, they're going right to the source. And when they go to the source, in 2017, they spent $380 billion on lobbying alone. So again, let me put that in perspective. There's another industry that we think about that spends a lot of money on lobbying, and that's oil and gas. When you look at how much oil and gas spent in 2017 on lobbying, it's kind of cute. So as I was learning and doing some research around lobbying and how much lobbyists spend, I did a Google search, and I found this in my Google search. They're not lying. It's true. For if you can't read it, if you are looking for a lucrative career, become a healthcare lobbyist. So what do all these dollars turn into? It's an industry, and an industry runs on jobs. Healthcare involves a huge proportion of jobs in the United States. And in fact, so the darker the state, the greater percentage of employment in that state is healthcare related. So let's look at our state. So North Carolina represent about 12 to 15% of jobs in our state are healthcare related, amongst the highest in the country, okay? But let's look a little bit closer, and let's look at our city. So if you look at employment by industry in Durham, look at the red, and you see that almost 20% of jobs in Durham are healthcare related, more than education. So almost 1 out of 5 jobs in Durham is related to healthcare. And this is why the answer to why haven't we seen healthcare reform is not politics as usual. It's because 1 out of 5 jobs in our community depend on healthcare. It's because there's so much more involved in how healthcare is delivered in this country than just politics. It's because so many people touch your healthcare and aspects of it before it gets to you. So what can we do? What are the steps that we need to take to tackle this, to change the way healthcare is delivered in this country? Well, that list is about 1.3 million items long. I have distilled it down to 5. Yeah, fully comprehensive. Number 1, we need to negotiate drug prices. We need to do what we can't do here, but what happens in Australia, in Europe, in the UK, and in Canada. There, as you know, Nancy Pelosi's bill to negotiate drug prices put a cap on Medicare out-of-pocket costs at $2,000 and to limit the increase in drug pricing per year to inflation rates. That bill passed the House, is now sitting in the Senate. I don't think there's anything important that's going to happen in the Senate anytime soon, so I'm sure that bill will get picked up very quickly. No, that bill is going to die a slow and painful death. There is a bill in this. In the Senate. There's a co-sponsored bill by Grassley and Wyden that does not address negotiation, nor does it address, I believe, Medicare caps, out-of-pocket caps, but it does limit the increase in drug pricing to inflation. The Trump campaign had talked about drug price negotiation. Since then, just in the past few months, the Trump administration has backed off of that point. Next, reduce healthcare administration. This is a really tough one, and I think the only way we can do that is by my number 5, which I'll get to in a minute. Number 3, lower physician salaries. To be honest, and of course I'm saying this from a biased viewpoint, most people would argue that physician salaries are a very small part of this puzzle, but I can't talk about cutting everything else without saying something that would impact me as well, so it's on the list. Don't call me biased. Campaign finance reform is a huge one. And honestly, I don't think we can get true healthcare reform until we take the money out of politics. But the last point is the one that most people talk about, but in a slightly different way. So I would say ensure everyone is in the insurance pool. So what I'm not saying is single-payer healthcare. What I'm not saying is Medicare for all. We don't have to do those things, but in some way or another, I mean, those are all ensuring that everybody gets into the insurance pool, but in some way or another, we need to make sure that happens. So why does that have to happen? So insurance depends upon being able to afford the most expensive because of the least expensive, right? So the way health insurance works is that the most expensive patients who are insured are paid for by the youngest and healthiest who are not using those resources, right? But if everybody's not in the healthcare pool, what you have is a really biased sample that leans in the direction of the most expensive, right? And insurance starts going through the roof. And that was the point of the individual mandate under Obamacare, right? Was to pull young, healthy people into the insurance pool and then decrease the cost of healthcare. So and we can talk when I finish up in terms of the candidates and what they're talking about and how they might be contributing or talking about some of these points. So that's the high multi-hundreds, if not trillions of billions of dollars of discussion in terms of why healthcare is so expensive. But I would urge you, when you talk about healthcare and healthcare reform, to realize that it's not always just politics as usual. Healthcare reform can and likely will impact jobs in your block, in your neighborhood. And I would urge you to remember how reform in any way, or healthcare costs in any way, impact the patient. Thank you. All right, so I think we have some time to chat. Yes? Yeah. So the question is basically around research and development. And how does research and development contribute to the cost of care? So anybody heard of CAR T therapy? Right? So CAR T therapy is immunotherapy. The first CAR T therapy that was approved for treating kids with leukemia cost about $500,000 per treatment, right? Really expensive, but really expensive biotechnology to develop, right? Do you know where the research behind CAR Ts was done? Sorry? Well, it was done at the University of Pennsylvania, and it was paid for by federal grants. I don't completely buy into the R&D argument. I will say that I think we're seeing more of a shift where R&D is now happening more and more within industry, and yes, that is expensive. We're seeing more of a shift where R&D is happening outside of the US. And again, there are people in the room who know drug development way better than I do and can talk about it better than I can, though the person who is nodding and smiling claims that she knows everything better than I do, so. So I do think there is some component to research and development. It was my wife, that's who I was talking about. But I mean, it falls into that innovation argument, right? So anytime you talk about why drug prices cannot be controlled, I think the pharmaceutical industry relies on this concept of innovation. And again, I don't completely buy that argument. I believe that a lot of the innovation happens outside of the industry itself. And I also know that the pharmaceutical industry makes a bigger profit margin, right, than any other industry. So even if you count for innovation, even if you count for R&D, I still think there's room to give. Yes?
Can I follow up on that question? Because now, how many innovative insulins are there? Are they any better than the ones that originally came around? And what we're doing is forcing people saying, oh, you're going to get a better insulin, but you can't afford it today. So there's a lot of manipulative arguments.
Well, I completely appreciate what you're saying. I may sort of back off on the term manipulative, because I really do not believe there is a bad guy here. I really don't. I believe this is a multifactorial, multi-stakeholder problem. And we need to talk about pharma as much as we need to talk about the insurance industry and hospitals and physicians and everybody else. But let me talk about your point of sort of Me Too drugs, which is really important, right? So again, in oncology, there's a class of immunotherapy drugs called checkpoint inhibitors. And there are these there were just a handful that were approved maybe 5 or 6 years ago. There are now probably 40 plus of these drugs in the pipeline that all have the same mechanism. So I think the pharmaceutical industry is motivated to make more of the same, because when the drug gets approved, it'll get covered. So this is not the fault of the pharmaceutical industry. This is the fault of government and insurers, where unlike other countries, we don't say, okay, we're going to cover the first 3 checkpoint inhibitors, and that's it. We're not going to cover the others, or we're going to cover the best 2 or the ones with the best data. Well, we cover everything that comes along the pike. And because of that, there's no incentive to truly innovate and to think about other mechanisms. Yes?
I'm just curious, because you mentioned malpractice insurance in your top 5, could you pick the top 10? I wonder, because I think if you throw in your salary, there was malpractice insurance, and we use the cost of med school. I think there are other factors that affect your salary.
Yeah. So, I mean, if you talk to the AMA, they would say it's a huge deal. I don't think it scratches the surface when it comes to some of these other issues. I think it is important, and yes, I would personally love to, no, that has nothing to do with my practice. I'm not saying that based on personal experience. I'm just, of course, right? I mean, I think there is a much bigger emphasis on malpractice lawsuits here than in the rest of the world, but I really do think it is relatively minimum compared to elsewhere. Yes?
Yeah, I had a question about your last point about making sure that everyone's covered and how that young, healthy people ought to, by buying insurance, subsidize those who are sick. How would you go about ensuring that young people who are at the nadir of their earning career are subsidizing those who are 64 years old before, before they're covered by Medicare? And would you consider that to be a regressive taxation?
So it's interesting that you call insurance subsidy, or a mandate for insurance a subsidy. And that is an interesting way to think about it. However, I believe that is less of, I think of it less as a subsidy as actually the definition of insurance. Because ultimately that young person is going to get older and will require that same degree of health care. And it actually decreases costs for that person as well, who's just entering, because insurance will be less expensive for that person as they enter the insurance market as well. So it doesn't I think you're right. I think it mostly helps the sickest patients, but it doesn't only help the sickest patients.
I guess in 1 year, if I'm somebody who's young and healthy, I will almost certainly spend, or I will utilize less health care than the amount of premium that
By definition.
So that is how I consider that to be a subsidy to other people who are utilizing more health care. And
Yeah.
I understand that your system only works if people who are healthy are in the insurance pool. But I guess my concern is that that is a regressive, whether you consider it tantamount to regressive taxation on those
Mhm.
who are at the nadir of their earning career
Yep.
to those who are at the nadir.
Yeah, no, and it's a very important point, and in fact, I think it is a point that many who are opposed to, for example, a single payer system or like a Medicare for all system may also make that argument. So it's a valid point. Yeah.
But as long as education is so expensive here, as long as we have a tort system that makes it difficult to practice without an additional layer of insurance. I mean, these are simple things. In Japan, it's possible, they make good medical devices as well. But an MRI in Japan can cost you $100 or so. And they did it from policy. The policy was medical practices cannot own the machines.
I hear you. Yes.
Yousuf, I just wanted to say from a social worker's point of view, I spent 35 years working at and then at Drug Regional, and as a social worker rather than working as a counselor, I was working primarily to get bills paid. And currently, we have a electrician who has worked very hard, and he has told me that last in his wife's divorce, his wife was not eligible for home insurance, and that he has adjusted to, as an electrician, having no insurance because he cannot afford it. And I heard this for 35 years. And for me, the idea that North Carolina legislature would not change, I think that probably has been overwhelming.
And to clarify, Trish, you're talking about Medicaid expansion.
It's remarkable that you cannot think that this would be an idea for working families. And I just wanted to put that out there because it is election season and people are impatient. But as a social worker, I cannot tell you how many hours, over 40 hours a week, I spent in this, and of course, you know that.
Yeah, thank you for sharing that. And, one point I will make, though, is that our NC Medicaid administrator is fantastic, and she has been pushing very hard for Medicaid expansion in our state. Yes. Arbitrary. Yeah. Yeah. So the question is, can we do something incremental, or does it have to be dramatic? So if you look at the Democratic candidates' platforms, Joe Biden, for example, would argue incremental, right? So his platform is basically built around bolstering, improving, adding on to the ACA. So yes, I mean, I absolutely think that there are ways forward with being incremental. And to be honest, not that you asked, but I'll tell you my opinion in terms of the Medicare for All argument. I have a tough time understanding why the candidates would spend so much time talking about a policy that will for sure never make it through Congress. I mean, you look at how hard the ACA was when both the House and the Senate and the White House were all one party, right? And the ACA was still so hard to get through. I find it so hard to believe that why they would spend so much time talking about a policy that's clearly never going to be anywhere near reality anytime soon, as opposed to these small incremental changes. But I can understand, from political sense why you would talk about it. But I think incremental is probably how things are going to happen anyway. Yes. Well, so yeah, so I mean, especially if you're thinking about the Medicare for All plans, like Sanders, Warren plans that eliminate commercial insurance. Yes.
Take it more to a personal level, the person you had. What happens when people don't take the drugs that they're supposed to be taking because of the cost? Does that give more costs into the healthcare system as people aren't doing what they should be doing?
Yeah, yes, absolutely. And in fact, this is where I really harp on the insurance industry, where we need to think about value-based insurance designs, for example, where there is no copay, for example, on really high-value interventions like Gleevec, right? But maybe a higher copay on really low-value interventions where there's no evidence behind it or something like that. So this is something where I think the insurance industry could do way more in terms of their insurance design. Doing okay? Yes.
What portion of the insurance is related to all of the care that isn't at end of life for elderly people? That's, in my personal opinion, not warranted. Like, it just extends suffering, it doesn't extend life.
So,
That just a piece.
yeah, so the question is how much does care at the end of life contribute to the overall cost? And in the sort of spectrum of where a patient is in their course of care, end of life is by far the most expensive. In a cancer patient's course, it's actually a U-shaped curve where initially at the time of diagnosis, it's really expensive, dips down, and then again at the end of life, it becomes much more expensive. But I do think you have an important point in that we have a culture that is still coming to terms with end of life, that is still coming to terms with hospice. And because of that, we often see overutilization of care when that care may be causing more harm than benefit, and maybe, you forget cost for a minute, but might be actually harming people when they could be benefiting from better palliative care, for example. Yes. I wish I had used that example. I don't remember. All right, so let me address what portion is drug cost. There's no simple answer there, and it varies within disease, for example. But like I said, for Medicare patients with a new diagnosis of cancer, hospitalization costs far exceed drug costs. And you never hear that because it's so much easier to pick on pharma, right? But it's actually hospitalization costs that are at the top, at the top there. Your other question was, are we subsidizing research for the rest of the world? Historically, much of the R&D, pharmaceutical R&D happened in the US. We're seeing a little bit of a shift now where it's happening more in Europe and in Asia, and even in China actually. We're still definitely doing the largest proportion of R&D is happening here in the US. So, and that's actually an argument that the pharmaceutical industry would make as to why prices are higher here than elsewhere. It's because a lot of that R&D that happens here is accounted for in that price. Yes.
Do you have a sense how changing demographics in the United States are affecting healthcare? So we have an aging population, we have a declining birth rate. So I would imagine that skews cost curve, in one direction. And as the demographic changes continue to happen, how does that affect what the picture looks like?
Yeah, that's a really important point. And I think demographics are absolutely contributing to our overall costs. However, I would also point out that that is a very similar, if not even more accentuated demographic of Japan.
What are your thoughts on the FDA and whether FDA regulation increases the cost of pharmaceuticals by creating a barrier to entry and reducing competition?
That's not where I thought you were going to go with that. So I think a lot of the argument that people are hearing right now is that there's actually not enough of a barrier at the FDA. that drugs are coming through incredibly rapidly with not enough evidence, and there's nothing that's not getting approved ultimately. I think we hear a lot from patient advocacy groups that it's not happening fast enough, and I completely understand where that's coming from. But if you look sort of at the pattern of approvals at the FDA, many would argue it's going much faster than the evidence would support. Last question. Yeah, I mean, I think, so I mean, you know, Duke advertises. Duke advertises a lot. I think advertising absolutely falls into the price tag. If you talk to representatives from the pharmaceutical industry, I think they would argue that research and development is a bigger piece of the overall cost than advertising is. I also think that advertising is probably relatively small in the whole scale. Okay.
What is your opinion about Wall Street and the effect on the end user as far as profit margin of driving?
Yeah. So the question is, what is my opinion on Wall Street? I sat down once with a former CEO of one of the largest pharma companies in the world, and he said something really interesting. He said, you don't think that I want the best drugs to come out of my company? And like everybody who works in my company, they want the best drugs to come out of the company so that we can benefit all of our customers. Like, that's why we're in the business. It's like, you're barking up the wrong tree. The people you need to talk to are the shareholders, because the shareholders are so far removed from patients where their sole responsibility, and it's the job of a shareholder, is to make sure the company is profitable, right? So again, it is how our system works. I strongly believe there is no bad guy. I think everybody has their view and their sort of interest and their lens of how they see healthcare. All I ask of you guys is understand those different perspectives and know that there's no one simple answer. Thank you.
Thanks again to Dr. Zafar. We will see you on February 18th. So thanks again.